last time we left off in a kind of a quantum in which we discussed most of the prosthetic designs which are available, but we still have a lot of discussions to continue with regards to where they're going to be implemented, as well as the different types of components, as well as types of processes which can be given in different scenarios. So I'll be doing a quick discussion today based upon the last time discussion, just so that to make sure that all of you remember what we have discussed last time, and then we'll go on to the newer part of it from today. So just to put it up in detail, starting off, as you can see over here, there might to be two examples of implant processes. One might be a complete fixed kind of prosthetics, and the other would be a removable processes as well. Okay, so this what you see on your left side is mainly an example of your fixed processes, which has something called as multi-unit abutments attached to it. The advantage of the multi-unit abutments are that I can easily use different angulations and attach them to the implant processes, whereas this is a removable processes. So what basically happens with regards to removable processes is that we can easily remove it and place it at will. Okay, so what happens here is that when you solder the different abutments together, we get something called a bar design. To this bar design, the denture can easily be attached, and as the surface area is improved, you can see a better retention bond compared to what you see with your normal complete dentures and your normal probably over dentures. Okay, so this gives you a better option, but you have to keep in mind this is still a removable processes, and this one is a fixed kind of processes. So this is the basic difference between your implant process and your fixed and your removable. Both of them can be removed by the clinician. However, only one of these, that is the one on your right, can actually be removed by the patient himself. So you would have to know a clear understanding of where to use something called a hybrid process, which is a fixed processes, and a removable process, which could be like an overdenture processes. However, it does not matter how many implants are involved. You can even have maybe 4 or 5 implants and still give a removable processes. So sometimes what I see is students think that if the implants are increased, I can automatically give a fixed process. No, there are other considerations also to know about before you decide whether it's a fixed or a removable processes. So I'll just quickly discuss all of this, what we had already discussed in the last class, just so that you have a good foundation on which I can build on today. Why we require implants? It replaces your teeth, can give you the option of a removable. As we all know, everybody prefers a fixed option. So wherever possible, we go for a fixed option. In such a case, your removable is not required. Okay. Also, I'm giving you a support for my denture. It should be removable, what I showed you in the last time. Areas where there's not enough support available, these provide you that anchorage, what you actually require. So all these reasons, you require dental implants. Okay. So this is what we discussed last time. I think all of you remember this still, right? Which of the following bones can be considered for immediate loading? Let's quickly just discuss this off. D1, D2, D2, D3, or is it D1, D3, and D1 only? Anybody? Let's quickly just answer this off. We had already discussed this in the last time. Just want to make sure that all of you remember this. What is the answer for this question? For immediate loading, what are we considering, right? So you have to let me know the answer for this. Is it D1? Is it D2? As we know, D4 bone is the worst kind of bone which is available, in which a normal implant as well will struggle to osseointegrate, right? So let me know what you think among these 4 options. We had discussed this the last time around. Perfect, very good. So I see D1, D2 as one of the answers, and that is your perfect bone, which is for any kind of implant procedures, right? You need a bone which is D1, D2. So what do we technically mean? So the answer is A, D1, D2, but what do we technically mean when we say D1 and D2? Okay, so you have to know this chart by heart. This has been asked numerous occasions, so you have to know. So just remember figures like these ones, right? So what happens is you have more amount of cortical bone, it is always good. So remember, C is better than T. You do not want much trabecular bone, you want more cortical bone. Okay, so what do I mean by that is that the cortical bone is going to help your bone have a better anchorage, is going to fuse much better compared to your trabecular bone. So remember, wherever cortical bone is present, my implant is going to be more successful, is going to integrate more successfully. So D1 bone is always preferred compared to your D3 or your D4. So your D1, also understand the tactical analog. The been questions they asked, D4 bone is equal to watch analog, you should know it should be styrofoam. Okay. So also know the areas where they are present. We discussed this the last time around as well. So know the description, analog, and the anatomical locations of all 4 types of bones. Know what D1 to D4 signifies. Okay. So when I'm going to talk about implants, supported restoration, like I was discussing in the first slide, we talk about both fixed, removable, and hybrid. Okay. The fixed is also subdivided into a different depending upon the mode of retention, as a screw retain or a cement retain, whereas a removable is just a normal placement and removal, which has a nice snug fit to the implant components. So what you also need to know from a prosthodontic base of view is a MISH classification, which signifies FP1, FP2, 3, RP4, RP5. There is no FP4, FP5. It's RP4 and RP5. Okay, so what you have to know is the difference between these 5. We discussed about 2 or 2.5 of those in the last time out, but I'll just discuss through and through with it so that you have a clear understanding about it. So FP1 replaces only the crown. Okay, FP2 replaces the crown and a portion of the root. That is what you have to know. FP3 replaces the crown, the gingival color, and the edentulous site. So this is used mainly if you want to replace the entire system, your teeth, your gums, as well as a portion of your edentulous site. That is your FP3. Where RP stands for removable. It must be understood. So you can see FP stands for fixed processes, RP for your removable processes. All right. So keep that as an understanding. Your removable processes, your RP4 is an overdenture supported completely by implants. Okay. So it is not taking support from the mucosa. It's mainly from the implants only, like a superstructure bar. Whereas an RP5 system takes support from both the soft tissue as well as your implants. That is the difference between your RP4 and RP5. Please keep in mind all the difference between all these 5 types of prosthodontic classification. Okay, so you should know what is 1, 2, 3, and what is RP4 and RP5. Quickly moving on to FP1, we discussed this the last time around as well. What does it do is basically just replaces the crown structure. Okay, where can I use an FP1? Where there is a minimal loss of my hard and soft tissues. Wherever I see a reduced amount of hard and soft tissues, or there is not much loss there, in that FP1 processes comes into play. Okay, so you have to understand this is also dependent on the position of your bone and position of your implant. This is a pretty straightforward concept in which only your tooth is missing. We place an implant and replace just the tooth component. That becomes an FP1 process. Okay. Coming to one of the MCQs which I want to discuss, we did this the last time around. Which material is best suited for an implant prosthetic or a crown or a bridge? Is it titanium? Is it a metal or metal ceramic? Is it zirconia? Or is it a patient's preference? Which, if you had to choose between the best material that is used for as an option for an implant crown or bridge, which would be your preferable material of choice? Would it be your titanium? Will it be a metal ceramic, zirconia, or you go with whatever the patient tells he or she wants? What do you think is the answer for this one? Anybody? We had discussed this the last time around. You go with patient's preference, zirconia. Okay. So for this question, what you have to understand is the fact that how much amount of forces are exposed by an implant compared to that of a normal dentition, right? So ideally, what we consider that material titanium is what your implant and your abutment is made up of. Okay, but titanium is still a core structure. So whenever you have remaining teeth present or a denture teeth present, the thing what you have to understand is we, as best possible, try not to abrade the opposing dentition. Okay, we should not harm the existing dentition which is there. Okay, if we have titanium or we have zirconia, both of them are very hard materials. So what they tend to do is they will abrade the opposing dentition, because an implant gives as amount of how much you're chewing, flexural strength is there, right? Whatever strength is done in a chewing cycle, your implant almost simulates the similar one as there is in a natural dentition. So if you give a titanium or zirconia opposing a natural teeth, or maybe even a denture or an acrylic teeth, it will definitely chip it off. So the material of choice, usually 95% of the times, it is metal or metal ceramic, because these materials will not harm your opposing dentition. The second choice is your zirconia. The third choice is your titanium. Zirconia mainly for purely aesthetic considerations, because there is nothing as aesthetic as a zirconia restoration. So, but given a choice, you have to consider the first principle of your tooth preparation, for example, preservation of structure, tooth structure, right? So if it's metal or metal ceramics opposing a normal natural tooth structure, it will not harm it compared to what a zirconia or a titanium restoration might be. Okay. For that, the answer should be B, metal or metal ceramic. That is your first answer. If acrylic is there, acrylic also is a good material of choice, because it's not going to harm your opposing dentition. Patient's preference usually does not come down in case of your implant restoration. That's purely your choice. Patient's preference you can probably take during your tooth preparation, of if you have crowns and bridges with your tooth support. Okay. This is with regards to your what material of choice you use. Similarly, we discussed FP1, in which you replaced only the crown structure. In FP2, what you do is you replace the anatomical crown structure and a portion of the root as well. So as you can see over here, some amount, because you can't keep a gap between the gums and the tooth structure, right? So you have to make sure you cover that surface as well. So come what may, in FP2 processes, if you see, suppose it might be questions like showing you this figure and asking you to recognize what kind of implant processes classification is this. So do not think that this is just FP1. You're replacing the crown and a surface of the root as well. Sometimes in these areas, we put something called a pink ceramic. That is to cover and not make the tooth look very long and make it look unaesthetic, right? We put some amount of pink ceramic on top of it. That covers a portion of the natural tooth as well as your root portion. This is your FP2 processes. Do not confuse it with FP1. Okay. So as you can see over here, if you do not do it, what we get is something called black triangles. Patient smiles, you can see these nice black triangle surfaces between the two teeth, which looks very bad when the patient smiles. So you have to think about maybe even soft tissue procedures to cover it up at a later stage. So coming to FP3 processes, what does the FP3 process mainly do is you are covering, similar to FP2, covering the crown portion, the root portion, but also the entire gingival design. Okay, so this also depends on whether the patient has a normal or a high maxillary lip line during smiling. Because if he has a high lip line, whenever he smiles, that's going to be visible, right, which you do not want. So FP3, as seen over here, replaces the tooth portion, the root portion, and the gingival portion of the entire surface which is missing. Ideally, this is mainly done in your full mouth rehabs or your full mouth edentulous cases, where both upper and lower have to be sorted out. You go for an FP3 process. Again, keep in mind, this is fixed. This is not removable, right? Now, coming to another MCQ, which I want to discuss to keep this discussion going. Which prosthetic option provides a better neuromuscular control and proprioception to a completely edentulous patient? Is it a complete denture? Is it an overdenture? Does it be the fixed implant hybrid processes, or is it an removable implant overdenture? Please read the question carefully, which provides better neuromuscular control and proprioception in a completely edentulous patient. So which, according to you, does that? Your CD, your overdenture, your implants, or your removable implant overdenture? Yes, please answer, everybody. I see a beep. Okay. Apart from that answer, anybody else? What do you think is the answer to this question? So you have your different options for rehabilitating a prosthetic maxilla or mandible, right? So what do you think would be the answer for this MCQ? We've all worked with CDs, we've all worked with overdentures. So the advantage we're talking about here is neuromuscular control and proprioception. I see B's, yeah. The answer is B, that is an overdenture. All right. Why? Because an overdenture, basically a tooth supported overdenture, it still has your nerve fibers intact. So what we do for an overdenture, if you have discussed this earlier, is that we have canines which are present, or we have two molars present on either side. We do an intentional root canal, and then we cut the tooth to about 75%, keeping about 25% intact. Even when we are cutting the tooth by 75%, we still have nerve fibers embedded within your tooth. So whenever you're being asked a question about better neuromuscular control and proprioception, even if implants are there in your options, your answer should always be B, overdenture. A tool-supported overdenture always gives you a better neuromuscular control. The second one will be a fixed implant hybrid prosthesis. The third one will be a removable implant overdenture. And the fourth one will be a complete denture. Complete denture has zero neuromuscular control and proprioception abilities. The patient learns those abilities over time. But your tooth-supported overdenture is your best answer. Okay, I see many of you got it right. Perfectly, very well done. That's B, overdenture is the answer that you're looking for. Okay, so we discussed FP1, 2, 3 in your prosthetic options of an implant. Let's now go over to a removable option. Now, the removable option, you have RP4 and RP5. Do not confuse it with FP4, FP5, which do not exist. Okay, so what is an RP4? Okay, you have to understand that it is also a removable process which is supported by your the implants, but not with actually here teeth or both. But now we don't follow the both concept. We do it either by implants or teeth. Okay, so where are we usually give it? Okay, so what you have to understand RP4 it's completely supported by a tissue superstructure or a bar structure. It does not take any support from your soft tissues or your mucosa. It is entirely reliant on your implants and the bar which you give. So what happens here is we differently give different types of implants, and we still, even if you're giving 5 implants or 6 implants, don't take it for granted that we give a fixed processes. Even if 5, 6 implants, you can give a removable process. So this is what it would technically look like. So you can see here probably around 6, 7 implants are placed. We solder these implants with the help of a bar. This is also a titanium substructure on which the entire units are soldered and they are fixed to your individual implants. So it looks like this. Your prosthetic denture, which is also made up of acrylic, will have the female component. So you have read about your male component and the female component in your FPD designs. It's almost a similar relation with regards to this as well. As you can see, it has holes over here, your metals, but these are also made up of a titanium material only in your metal part, right? So when this is placed against this, it has a nice snug fit in the patient's mouth. But keep in mind, the mucosa or your soft tissues are not doing anything for retention. The entire load is being borne by your implants and your superstructure, that is the bar in this case. Everything in case of your RP5, there is equally shared. In your RP4 concept, even though you have 6, 7 implants placed, these implants are being soldered together or joined together with the help of a titanium bar on which your denture rests. Now, this is removed by the patient and hygiene is maintained as similar to your complete denture. This is referred to as an RP4 concept. Okay. Now, don't confuse ever with the RP5 concept. Now, what is an RP5 concept is that you are taking the implant support as well as your soft tissue or the mucosa support. So in this case, implants are slightly reduced. Okay. As you can see over here, even if you have bone in the anterior, you do not have good bone in the posteriors, you can't practically place an implant. So what you do is you maybe place 2 implants or maybe 4 implants in the anterior region, and you take the support of the mucosa in the posterior region and you share the load which is going to be acting on the prosthesis. So this becomes something called as an RP5 design. So as you can see here, the denture is used in which the implants is being placed on top of it. It will still have a nice snug fit on top of your mandible. It can also be given in cases of your maxilla. What the thing you have to understand the difference between RP4 and RP5 is, in case of an RP4, you require more number of implants. In RP5, you can still do it with 2 or 3 implants. The second thing what you have to keep in mind is in an RP4, now you see how big the bar is, right? So if the patient has very little vertical dimension, right? So your vertical dimension, again, you cannot increase or decrease just because you're giving an implant. It has to be according to the patient's established vertical. Now, if the vertical dimension of the patient is less, I cannot give a bar because the bar itself, as you see, needs at least 7 to 8 millimeters to survive. So I'm removing almost 7 to 8 millimeters of the patient's vertical. So if the patient has probably 80, 82 millimeters, 78 millimeters, it is still okay in which I remove 8 millimeters and give him a process which is nicely retentive and stable. But if the patient has probably just 60, 62 millimeters of vertical, I can't possibly remove 8 millimeters and give it to them. So patients where the vertical dimension is very minimal, I cannot give an RP4 processes. Similarly, areas where bone is not present enough, in which I cannot place enough number of implants, I can't give a RP4 processes. I have to survive with the RP5 processes, which requires lesser implants and does not require me to have a large vertical dimension because it is not taking up. I'm not soldering the implants. They're just going to be sitting like joints, right? That is what you have to know difference between RP5 and RP4, which can be asked in your exams. Okay, so this is what is the gradual difference. As you can see in RP4 and RP5, I can use probably 3 implants and give a nice RP5 processes in which I will not solder them. But in an RP4, I need more number of implants and I have to solder these processes together. Okay, so I just wanted you to clearly know the difference. FP1, 2, 3, we discussed in the last class, but you have to know FP1, it replaces only the crown structure. FP2 replaces the crown and a portion of the root, while FP3 replaces the root, the crown, and the gingival portion of your processes as well. Okay, that is the difference between your 3 fixed processes type. But in case of your RP, there's only RP4 and RP5, 2 types. RP4, it is more number of implants in which the mucosa and the soft tissue do not act as support. Only the implants take up the majority of the bulk. But in RP5, it's shared between the mucosa and your implant systems, right? RP4 vertical dimension has to be large before you place the processes, whereas RP5 does not matter. So keep this in mind whenever you're discussing the different types of implant prosthetic designs. I hope this is clear. You can ask me if there are any doubts. I'll be very happy to clear them up for you as well. Because these are the different prosthetic systems which are given by Mish. These have been asked innumerable number of times. So you should have an idea about all of these systems. Okay. So coming to an option where you want fixed or removable. Now you will be asking me why do I have to go for an FP3 when I can go for an RP4 system, right? Because an RP4 is going to directly derive its retention and support from the implant itself. So, but you can see the number of implants are almost similar for both an FP3 and an RP4. These are your advantages of an implant over denture versus an fixed hybrid processes. I can use lesser implants. I don't need to do bone grafting, easier hygiene maintenance, right? Because it takes support from the mucosa and the implants, I still have a better support and stability, right? Is lesser laboratory charges because I'm not using the entire one. It's easier to repair. But then fixed is always fixed. Patients always want something which are less, difficulty to remove, place, clean it, place it back in your mouth. They don't want all that headache. So for them, we usually give a fixed processes. Fixed is better from a patient point of view, from a doctor point of view, from our point of view, because of reduced stresses on the implants, easier to fabricate, lesser bone grafting, and lesser implants required. We still prefer a removable. Patient insists on a fixed. We don't have a choice. We gauge it. But you should know the majority of the removable is possible. Okay. So now you have to know what is an implant supported over denture and a removable denture. The normal conventional denture is what you provide, right? So what is the implant basically is doing is It preserves the bone quality because, like we said, it acts like an anchor. So anchorage is always present. It works and feels like an almost your own natural tooth. It is stable, it is retentive, and you don't need adhesives or creams. Whereas all that is a opposite in case of a complete denture. So if you're convincing a patient or you want to know what is the exact difference between an implant supported, these are both removable, right? The patient will ask you, they're both removable. Why should I have implants? So this is the reason why you'll be giving an implant over a fixed processes. Okay. So also the psychological benefit is a lot. Patients, like I told you, always prefer something which is more snugly fit, which is more stable than compared to your dentures, which easily slip off, especially your mandible ones. Attachments are not required, and the movement, because they slip, they're mostly tightened up to these implants. The movement of your implant support is very less compared to your conventional removable dentures. Okay, so a small discussion which I also wanted to cover. Given a choice for a prosthetic replacement of a complete edentulous individual, what would be your ideal treatment replacement option? A complete denture, a hybrid implant denture, a removable implant bar over denture, or removable implant ball over denture. So when I say ball over denture, I'm talking about RP5. I'm talking about bar over denture, I'm talking mainly about RP4. Hybrid implant is mainly your FP3 as well, or is it your normal complete denture? What would be your option to replace a completely edentulous individual? What do you think? We'll go with a normal complete denture, which all of you have done in your college days as well. So do you want to move towards a hybrid implant, or you prefer the removable option with regards to a bar or a ball over denture? What would be your preference, anybody? RP5. So basically, you're saying implant ball over denture. Okay, good. Anybody else? What would be your preference? You want to go with a different type of dentures, or if you are happy with going with RP5, there's a removable implant ball over denture. Anybody else? B, hybrid implant. Okay, this is a fixed option. Okay. So we have both the types. So given a choice, what would you ideally prefer? Ideally would be to think about the stresses involved, thinking about the hygiene maintenance and everything. A removable implant ball over denture is the preferred choice, right? That is D. The D is your perfect answer. If the patient insists, why I would go with D is because less stresses on the implants, the bone is still preserved, and I'm still sharing my load with my mucosa and my implants. If it breaks, I can reline it very easily. And the last one is I need very few implants. I don't need to place just for the sake of placing implants, right? Yes, it does depend on the socioeconomic status and the preference of the patient. The patient is insisting on fixed, right? In such a scenario, your hybrid implant, your answer would be B. Like we know many of them prefer B, but with B, the number of implants are going to increase because the stresses are going to be more. Second one, we could have to join them together using multi abutments and not the normal abutments what we use. They are also costly, and the prosthetic part of it is also more expensive. Apart from that, hygiene maintenance is an issue. So probably 5 years, 6 years down the line, the patient does not maintain hygiene. There will be a lot of bone loss, and even your implants will fail. Later, patient come back to you and say, "I paid so much for a fix," and 5 years down the line, it has started shaking or the implant has failed, right? So ideally, from a physician lower point of view, what we do is, especially in a country like India, we prefer removable implant ball over denture. Because even implant bar over denture is also expensive. Not to mention that it does not take any support from your mucosa. So again, the stresses on both your B and C are similar. But with your D, it's being shared, so not much forces are falling on your implant surfaces. So because of which you can preserve them for a long time. Ideally, we don't do a patient's choice. From a Mish point of view, and Mish, the person who actually wrote all your implant journals and books, also suggests a RP5 concept, compared to the others. But in the end, it comes down to what works for you and what the patient desires. So we cannot fully ignore those requirements as well. But this was a question which was asked in one of the exams, and for answer preferred verbal is also D. Okay, so you have to just remember this. So whenever I'm talking about an RP5, I'm talking about two implants, ball. This is called as a ball abutment over here on both sides, to which the denture will easily seat on. But when the same thing when I'm going to do with a bar, right? With a bar, the retention what I'm obtaining will still not that great. And like I told you, the vertical dimension you have to think about, because this bar is going to act right across the surfaces. So you have to think about where I'm going to give a ball abutment and where I have to give a bar whenever I'm doing the RP removable RP type of case. Okay, so this is what you have to understand between the difference between a ball abutment and a bar supported overdenture. Okay. Now coming to slightly from a prosthetic material or a dental material point of view, which is the preferable material for impressions to fabricate and implant prosthesis? What do you think is the most preferable material? You've all done your dental materials, so you've gone through the different types of agar, alginate, your elastomeric impressions. So which would you prefer for making impressions, but for an implant prosthesis? Can I rely on my tried and tested alginate? Do I go for polyether? Do I go for polyvinyl siloxanes? Or do I go to my polysulfides for help? Which is the most preferable material for impressions in an implant prosthesis? That is the key over here. What would you go for? Alginate or your different types of elastomeric materials? Which is your preference? Anybody? Can you answer this? You have plenty of options to choose from. What would you be your best chance for an implant prosthetic? Alginate or your polyether, your vinyl siloxanes, or your sulfides? Okay, I think not many of you answered this one. C is I see an answer. Polyvinyl siloxanes. Okay, good. Does anybody agree, Dr. Shruti? C. Perfect. Good. So the answer for this is C. Right? Polyvinyl siloxane should always be your material of choice with respect to your implant processes. We do alginate, but that is not advisable. Polyvinyl siloxane should be your go-to material. Question is why, right? Well, the main thing is that it is very stable. Among all your impression materials, it is the most stable material available to you, and it has very much less toxicity with regards to design. So given a choice, always go for your polyvinyl siloxane. Your second material, if polyvinyl siloxane is not available to you as an option, then polyether should be your second answer. Okay. The third answer can be your polysulfide, and then comes your agar and your alginate. So come what may, do not directly shift to your hydrocolloid impressions. Another thing is sometimes they ask you about the consistencies or also the different types. So we know that also there's something called adhesion silicon and condensation silicon. If they're asking you about those types, always understand that your adhesion silicon is much better compared to your condensation silicon. Okay, so you have to keep that in your mind as well. So if the material of choice is being asked, polyvinyl siloxane, why? Mainly because of the stability and the less amount of toxicity. The second answer is going to be your polyether. The third comes your polysulfide and then your hydrocolloids. With regards to your silicons, your adhesion silicon is always going to be more superior compared to your condensation silicon. Because I want you to keep this in your mind whenever you're asking or ask questions about implant impressions as well. Okay. So there's one more thing what you have to understand is the impression making technique. Okay, so the answer for this question was polyvinyl siloxane, that was C. Okay. If polyvinyl siloxane option was not there, your answer would have been D, polyether. That is your second best. The third best is your polysulfide, and the fourth best is your hydrocolloids. Okay. So now you also understand with regards to what technique of impressions are there. There are two major types, that is your closed tray technique and your open tray technique. So what we do is after you've placed your implants, right, we remove the cover screw and we put something called a healing abutment or a healing screw, what you can really see here, right? So once this is placed, the gum around the implant would grow according to the healing screw or healing abutment that you have screwed onto the implant fixture. Once that is done, you place something called a impression coping. Okay, this is referred to as a impression coping, which are attached to the implant body. Now, this is a closed tray technique. What do you mean by closed tray? In a closed tray impression technique, we do not make a gap or a hole inside the tray, but we pick up the impression the same way. Okay. So what you've done is you've removed the healing abutment. You remove this one, what you see over here, and place these long tower-like structures, which are called as impression copings. Once you attach the copings, you put the polyvinyl siloxane material around the impression coping and also on the tray, and you pick it up. Okay. So once you place the impression, place a tray on top, it will record your impression coping. Remove the impression, you will see small holes inside the impression, right? So you unscrew the impression coping from the patient's mouth and you attach it into the impression. This is referred to as a closed tray technique. Simple, you're removing the healing abutment, placing impression coping, flowing polyvinyl siloxane all across the impression copings, putting the impression tray inside, recording these fixtures, impression copings, what you have placed, removing the impression coping from the implant and placing it back into the impression. This is referred to as a closed tray technique. So for example, you have the structures present, you're not making a hole or anything in the tray, you're just placing it, recording it, and you're transferring these impression copings into the impression. Okay, so this is an example of a closed tray technique. What are the advantages? Yeah, so I'll just think about. So also one more thing, this is your in open tray is the gap what we make across the trays present. Okay, so this is closed tray is more easier from an impression point of view compared to an open tray, but accuracy of an open tray technique is much better compared to a closed tray. Also, an open tray requires sometimes a custom tray to be fabricated by your lab. So for that, you have to be careful. So this is also a method of retention, I discussed earlier, referred to as screw retain or a cement retain. Okay. Before I discuss this, I just want you to answer this question: which is an ideal implant prosthetic retention technique for implant health? Okay. So understand the question properly. Which is an ideal implant prosthetic retention technique for the health of the implant? Is it screw retain? Is it cement retain? Is it a combination technique, or is it none of the above? You want to maintain implant health. So do I go for screw retain? Do I go for cement? Do I go for a combination technique, or I go for none of the above? What do you think is the perfect technique for improving the health of the implant? Anybody? I see A, good, screw retained. Yes, everybody agree with A? All right, good. So whenever we're talking about implant health, what we don't want is some amount of cement to leak into the area or the gingiva around the implant. What happens if cement is there? It is going to slowly cause a gingivitis, which cause periodontitis, leads into bone loss. Before I answer this, this is what we refer to as a screw retain technique, in which the abutment is attached to your crown. Okay, abutment is that component of the implant which joins your implant to your prosthesis. That is your crown. Okay, so in your screw retain, it is already it's fused to the crown, and you just have to put the screw inside and screw it to the implant. The advantage of screw retain is that no cement is required and easy access to the screw. The disadvantage is that first one is the cosmetic appearance. You cannot have a show through of a screw in your anterior cases, right? Also, the crown may chip near the access hole because in that area it is slightly weak ceramic present. When I say I mean metal ceramic which is present. These are the disadvantages of your screw retain. So you cannot use it for anterior cases and there is chances of screw breakage. But the advantage is that implant health is sustained and you can easily retrieve your implant prosthesis. But in case of the cement retain, what you do is you fuse the abutment to the implant, add some cement on the crown, and you cement the crown to the abutment. The same way how you cement a crown to the natural tooth, right? That is referred to as a cement retain. So the advantages are the aesthetics. There is no screw opening hole, okay? That's called as access hole. It is not there in case of your cement retain, okay? So it looks like a natural tooth and it's more aesthetic in appearance. But the disadvantage is that cement can cause inflammation and bone loss, so it is not good for your implant health. And removing this becomes difficult because I don't have an access hole to open it. Retrievability becomes a factor. So nowadays there's something called as a combination technique in which we do a screw plus a cement. How do we do that? Is that we keep the screw and we attach it to the prosthetic outside the patient's mouth. All right. And the lab gives us a small hole. So when we are adding the cement to the abutment outside the patient's mouth, some amount of cement seeps away from the access hole. And then that we attach it into the patient's mouth. That is referred to as a combination technique. It is an advantage of both screw plus cement. However, even that is shown to somehow affect the implant health with some amount of cement still seeping out at a later stage. So at the moment, the answer is A, that is screw retain, which is best for your implant health. For aesthetic, the same question can be asked in a different way, which is best for aesthetics. In aesthetics, your answer should be B, that is cement retain, okay? Because I cannot give screw retain in your aesthetic cases. I hope this is clear with regards to your retention mechanisms of your screw as well as your cement retain prosthesis, okay? So this is what we have to understand whenever we are designing an implant occlusion. I was talking about the type of processes what we use. Your implants are trying to simulate the same amount of jaw movement and forces what your natural tooth have, right? So minimize harm to the opposing and adjacent tooth. How do I do that? Is by making sure I give something called implant protected occlusion, in which there is not a very tight contact or a occlude or a bite between the implant processes and the natural tooth. This is what you have to understand whenever you're designing an implant occlusion. Protect the implant, maximize occlusal function, but at the same time minimizing your harm to the opposing teeth. Minimize wear of occlusal surfaces by using metal or metal ceramic crowns rather than your zirconia or your titanium. Minimize the risk of your implant fracture and reduce the risk of the fracture again of your body or your natural tooth. This is what you do understand whenever you're designing occlusion for an implant prosthesis. So suppose this question was asked in one of your MCQs, identify this component which is used in rehabilitation of an implant. What would be your answer? So we know your NEET as well as your All India board is very fond of picture-based MCQs. So they might just throw out one component and ask you to identify it. So that's what I'm doing right here. Which is this component? Is it a straight abutment? Is it an impression coping? Is it a lab analog or an angulated abutment? Which one of this is this? You have to know your component systems, right? So which do you think is this? Anybody? Which among the four? How do I distinguish between the different types of components which are used in your implant system? So you see A for a straight abutment, okay? Okay, so see this perfectly well, all right? So you see this surface, right? Has a nice depression. The same depression will be present on all the three surfaces. This is only there so that you record it perfectly. This is referred to as an impression coping. Okay, so this is an impression coping for a closed tray impression. Okay, I will also show you what the other components look like. So just keep in mind, this is an impression coping, and you can identify it by the grooves which are present on all the three sides. Okay, this groove is what is important for you. So this, whenever you see, blindly go for an impression coping, because this is standard for all your implant systems. This is referred to as a coping. These are your other components of an implant system. Okay, so I will just go through them very slowly for you. This is what an abutment looks like. These are your straight abutments, what you see over here. These are your straight abutments on side which this is an abutment screw. So this screw goes into this abutment hole, right, and engages your implant completely. This is a straight abutment. What you see behind over here are angulated abutments. Okay, so you have a straight abutment, you have your angulated abutments as well. What you see over here are your impression copings. This is the closed tray impression coping, where you can see the screw which is very much top of the head, and this is an open tray impression coping. There's a much big difference between both of them. So I have straight abutments, angulated abutments, closed tray impression coping, open tray impression coping, and this is referred to as a lab analog. Okay. Now, whenever you attach an impression coping, this will go and fit into this lab analog. Now, what is a lab analog? Now, the implant is there in the patient's mouth, right? So, if you transfer the impression coping into the impression and send it to the lab, he will not know what to attach it to. So, a lab analog, which you can see over here, helps to simulate exactly what an implant position is in the patient's mouth. Okay, so to this impression coping, the lab analog is attached. This is what you have to know. So do not confuse yourselves. Straight abutment, because it is straight 90 degrees, right? These are angulated abutments, because you can see this angulation could be 15 degrees, 20, 25, 30, 45, whatever. There are different angulations available. These are called as angulated abutments. These are open tray impression copings and closed tray impression copings. Okay, and these are your lab analogs. This is a system which is there in all the major implant companies. It doesn't change. This one, what I showed you here, is from the denture company. This is from the Noble Biocare, as well as your adhesion systems. Okay, for example, this is an abutment again in this system. Your closed tray, open tray impressions. These are your analogs. This is a healing abutment or healing screw. And that's the same thing which varies with the type of implant which is available. So you should just have the basic knowledge of what abutments look like, what my impression coping looks like, what my analog looks like, and what my healing screw or healing abutment looks like. Okay. So if you have this much, if they ask you an MCQ to identify what is what, I'm very sure you're going to be perfect. Okay. So this is what the question I had asked you earlier. So you can see the groove which is present over here, and that is an used mainly in an impression coping. This engages the impression. You pick it up with your impression material, your polyvinyl siloxanes, send it to the lab. The lab will attach your impression coping to the analog, all right? And they will be able to simulate the exact position of the implant and the design to fabricate your prosthesis. So this is with regards to your implant prosthetic components. Perfect. Yeah, I hope you have no doubts regarding the different component systems. And before I complete, I just wanted to discuss this, which I felt was slightly important. This concept is becoming very easily available to you. There is a concept of platform switching. I'm pretty sure not many of you are aware about. I just wanted to discuss. If you had to say, what is this based on? What do you think it is? Is it a larger size abutment on a designated implant head, small abutment on an implant, similar abutment on an implant head, or smaller size impression coping on an implant head? If you had to guess, okay, I don't expect you to know this. This is a slightly advanced level question, but I'm pretty sure such questions are going to have one or two bouncers. So I just want to discuss this concept before I left you. Concept of platform switching. If you had to guess, what is it based on? Large size abutment, small size abutment, similar size abutment, or a smaller size impression coping? If it's a lucky day, I'm sure many of you get it right. So you just have to guess what will be your best guess be. Because there will come a time which you'll have to guess a lot of questions in your NEET exam as well. Anybody? I know they'll all look very similar, the options. Okay, I'll just discuss the concept with you. Okay, so what basically is platform switching is, earlier what we used to use was, this is an implant on which we used to place an abutment. Okay, so when we place an abutment, what we noticed was at the junction where the implant meets the abutment, there was a lot of bone loss occurring around the implant surface. Okay, so when we used the same size or we used a larger size, the bone loss was increasing. So then what we did is we started using a slightly smaller size abutment compared to the implant head. Okay, so what we are doing is we're preparing, this is the abutment. We use a one size shorter than what the implant we have placed abutment, and we saw that the bone was actually increasing. So better the bone, better is the success of your implant and your implant prosthesis. So the concept of platform switching mainly involves using a smaller size abutment on a designated implant head. The answer is B. Okay, this is a concept which is being very famously used in the last 4 or 5 years, right? We have been too much with this concept, which is why I feel some bouncer like this might just turn up in one of your exams, which is why I wanted to know this. Just keep in mind that it's a smaller size abutment on a designated implant head. Why is it done? Because when a normal size was used, 1 to 2 or even up to 1 to 4 millimeter bone loss was observed. So we started using one size smaller abutment, and we made sure that the bone loss was completely reduced. This is referred to as the platform switching concept. Okay, so what I wanted you basically to understand with regards to your implant prosthetics are the different types: FP1, 2, 3, RP4, RP5, the difference between all of them, the difference between fixed and removable, the impression techniques, the different retention techniques, screw retention, cement retention, which is better, and platform switching concepts, right? I wanted you to be aware of all these concepts so that you can answer any questions with regard to an implant prosthetics easily, right? So I hope this has been helpful to you all. I'm very happy to answer questions if there are any doubts as such with anything which we discussed today. Anything you want me to repeat, which is slightly over? We still have a couple of minutes in which I can pretty fast finish that, if you want me to deal with it. Or if you've understood, it's very well and good. Any questions as such, please let me know. Yes, I think it's understandable. Okay, I think most of you understood most of very good. If you understood this, very good. It will be helpful even if not in your need, in your different clinical scenarios as well. So I hope this was the last 15 minutes have been slightly useful to all of you. Yeah, okay. So I think most of you have understood the entire thing. Most welcome. Best of luck, everybody. Keep studying. I know you will want to finish it off as fast as well. So best of luck. Keep studying, and I'm very sure everything will go well. Yes.